Welcome back to everybody. Very nice to have you back in your seats and paying attention so perfectly, so thank you very much. I wanted to just make a couple of announcements. For the doctors in the room, there's a survey that looks like this. That's available to you that we would very much appreciate you filling out. This will provide an opportunity about what we might need to do next in terms of training and opportunities like this. So that's number one. Number two, any of you that are going to be receiving CEU credits, there is a doodle poll that you'll need to make sure you fill out so that we can move forward. So I would like now to call Dr. Jacqueline Teese up. Jacqueline received her doctorate of optometry from UC Berkeley and practices at Kaiser Permanente in San Rafael. In addition, she's the founder, director, and key researcher and clinical instructor for UC Berkeley Sports Vision Institute. She's well published, a recipient of many, many honors, and she is also an athlete with 8 marathons under her belt. Welcome to you, Dr. Teese.
Good morning. I'm really excited to talk to you guys today. I'll move that too much. About concussion and vision. It's something I'm incredibly passionate about, and it's pretty much the majority of what I do all day, in addition to some other things. So I'm a neurooptometrist. Let's start there. What's a neurooptometrist? A neurooptometrist is somebody who went to optometry school and then did an additional residency in neurooptometric assessment, visual rehabilitation, as well as binocular vision. So I specialize essentially in double vision and eye movements. I do clinical research on the side, and my financial disclosures are listed here. My research is funded by the UC Regents and an NIH SBIR. Today we're going to talk about the current vision protocol for screening after concussion, which, to be honest, on a national level is pretty slim. We're going to go through the most common visual signs and symptoms you're going to see after a concussion and their predicted timelines for resolution. And we're going to go through this kind of through an anatomical pathway, because sometimes our vision symptoms often get missed. And we're going to go for the current, future, and role of vision in concussion. We've talked a lot today about how hard it is to diagnose a concussion. And one of the main reasons for this is our definition is continuing to evolve. What was once a concussion 10 years ago may be diagnosed as a concussion today, and our definition may continue to change. So as of right now, we call it a functional disturbance of brain function because there's no structural injury that we can find on a lot of our current diagnostic measures. So we do a lot of things that we can try to do a pretty multidisciplinary battery to see how we can see if somebody's had a concussion. But a lot of the times we're relying a lot on symptoms. And unfortunately, our patients aren't the most reliable people. Sometimes they have a lot of motivating factors that might make them overestimate their symptoms. Say they were in a car accident and now they maybe are under a lawsuit. Or maybe we're an athlete and we really want to return to play, so we're going to pretend that we're fine. And this makes it really hard for clinicians to diagnose and manage it because we're relying on someone that isn't the most reliable. And oftentimes the tests that we have out there for sports-related concussion are helpful because we can get a baseline on athletes, but sometimes we get concussions in people that don't have a baseline, and then it's really hard for us to diagnose it. And this is really where the roles of eyes are starting to play a really big part in how we can diagnose and manage concussion, because the eyes have a potential to be an objective biomarker for brain dysfunction, and they're also being looked at for active treatment of concussion symptoms to see if people can actually get better faster. When I tell people that I specialize in concussion, they oftentimes look at me like I'm crazy because they think that's a very narrow specialty, and it is. And they also wonder, how often are eyes really involved in the brain? And the eyes, while we see things with the eyes, vision is actually much more complicated. And about 55 to 70% of your brain is dedicated in some way, shape, or form to vision. And so I made this slide to really simplify the neurology of eye movements for you guys. So let's pretend that a soccer ball is in front of you and it moves from the left to the right. So a soccer ball moves in front of the eye, and the light signal from the soccer ball gets transmitted to the retina. The retina translates that light signal into a chemical signal and sends it down the optic nerve. You have 2 eyeballs, so they crisscross some of the information at the chiasm, and then they go to the LGN, and some of the information goes to things like circadian rhythms and sleep, and then eventually the majority of the information ends up at the occipital lobe. And this blue pathway is really the main pathway that we think of for vision. We don't really think beyond that. But this is just how the visual information gets into the brain. It hasn't even been really organized or processed at this point. So the rest of the information actually gets shuttled to different parts of the brain. So the occipital lobe organizes the visual information, and then it sends it to the temporal lobe. And the temporal lobe is the ventral or the what pathway. So the temporal lobe kind of talks to the hippocampus and some of the language centers, and it says, you know, this black, white, round thing, I've seen it before. It's called a soccer ball. And at the same time, the posterior parietal lobe gets the information, and it says, well, I don't know what this thing is, but I know that it's moved from the left to the right, and it's now located over here in relation to where I am in space. So that's the dorsal or the where pathway. And then your parietal and temporal lobes send that information to the frontal lobe, and depending on how you feel that day, your frontal lobe makes a decision on whether you want to follow the ball with your eyes. So the frontal lobe actually makes the decision and initiates the signal for eye movements, so it sends it down to the brainstem. Your brainstem then coordinates all the cranial nerves and muscles that are needed to make sure that both eyes move at the same speed to follow the ball. And of course, when we're following the ball with our eyes, we want to make sure we don't fall over, so the cerebellum and the inner ear kick in to make sure that we're balanced while we do it. So you can see in something as simple as just following a soccer ball from the left to the right, we've actually just used every single lobe of our brain. And so this is why people are now looking at eye movements as being a really good predictor and sensitive biomarker for brain dysfunction, because there's a lot of places where you can get some swelling in the brain and have trouble with your visual system afterwards. But currently, we really only screen vision in the traditional sense of a physical symptom of essentially blur or double. Sometimes I'll throw light sensitivity, but usually light sensitivity people don't necessarily refer to an eye provider. So in actuality, while yes, some patients will have double vision and blurry vision after concussion, in actuality, the majority of patients that I see actually have reading difficulties, fatigue, headaches, eye strain, focusing problems, but not necessarily blur, tracking problems, visual-derived nausea, inattention, or they get a lot of anxiety when they feel visually overwhelmed in a crowd. So for the rest of the lecture today, I want to mainly talk about what in the visual pathway might be causing some of these signs and symptoms and how they may overlap with other fields. Because oftentimes, the symptoms that I have listed here on the right may get sent to a neuropsychologist or a neurologist, and they rarely get sent over to an eye provider. And again, unfortunately, not all eye providers do the same eye exam. So you need somebody that specializes in how the eyes work with the brain or how the eyes move. So let's start with what we know. We all know the afferent visual pathway because it's taught in most anatomy classes if you're going to be a clinical provider. So the afferent visual pathway starts with the eyeballs and ends up at the back of the brain. I'm going to put a lot of slides up here that show the anatomy of the brain, mainly so that you can see that the visual pathway takes up a lot of space and it's all over the place. So sometimes you'll have one symptom but not another when you're having a concussion. The afferent visual pathway is pretty well protected inside the brain, so I rarely see an afferent visual pathway lesion unless somebody really got hit in the eye. So the way that we screen the afferent visual pathway is with color vision, peripheral vision, right, like Dr. Goetz was saying, with the finger counting, eye acuity, eye health exams, and pupils. And just like in concussion, eyes can get damaged when you get hit in the head, right? So you get hit in the head and your skull, your brain jiggles in the skull. Well, your eye at the same time jiggles around in the orbit. So the inflammation you get in the brain, you can also get in the eye. So you can get traumatic iritis. There are cases of traumatic optic neuropathy, retinal changes, fluid inside of the retina. So essentially, if somebody's complaining of flashing lights, not the weird sparkling ones they talk about, I'm talking lightning bolts in their vision. They're having floaters. They have reduced distance visual acuity that you can measure in your office, and it's not fluctuating, it's really reduced. You need to send them to an optometrist or an ophthalmologist to make sure they actually don't have damage to the eye. I'm going to go back a second. Pupils can be an issue as well. Now, there was a recent paper in 2015 that came out, and it was actually the first paper that looked at how pupils change in a concussion. And it was the first paper because we finally got a tool that was able to really look at how sensitive pupils can change. And if anyone's an eye provider, I recommend that you read this paper because it's incredible how many different parts of pupil pathways can be affected. If you're not an eye provider, let me summarize this study for you. The pupils are slow. They're slow to constrict, they're slow to dilate, and they don't always work very well together, so there are subclinical amounts of anisocoria. What does this mean? Subclinical means you can't see it, but it's maybe a 0.5 to 1 millimeter difference. So if you're seeing anisocoria, and this is why I put a question mark on the slide, if you're seeing anisocoria post-concussion, I would rule out that, it's not a subdural hematoma or a traumatic cranial nerve 3 palsy or really something that's much more diagnostically concerning before you just assume it's from the concussion. But now that I've read this article and all the pupil problems, sometimes I wonder if this is one of the reasons that we have so much light sensitivity. However, science hasn't figured out how to catch up to my questions yet, so we're still trying to figure light sensitivity out. But what do we know about light sensitivity? Well, we know that it can either be caused by the eye or it can be caused by the brain. If it's caused by the eye, your patients are going to come up to you and they're going to say, I have light sensitivity in my left eye only. And if it's from the eye, oftentimes it's from traumatic iritis or a tear in the pupil. And the reason that's important is because when somebody comes to my office and they have light sensitivity from a traumatic iritis, I dilate them and they actually feel better because the pain is from a spasm of that muscle. Now, if somebody has neurological photophobia and I dilate them, just like the rest of the population, they hate me because I just made them more light sensitive. But if we can actually fix the light sensitivity for that few patients that have traumatic iritis, we want to make sure that we do that. So let's talk about how we manage neurological photophobia. Science doesn't know why we have it. We have it in blast and non-blast related TBIs, and we have it in other conditions like migraines and things like that. So management-wise, sunglasses outside, always okay. We're all eye providers, and we always say that you want to protect yourself from UV light, but we actually want to avoid sunglasses when we're indoors, and I think this is oftentimes something that we don't necessarily recommend to our patients right away. And the reason is studies have shown that if you wear sunglasses indoors when you're light sensitive, you actually dark adapt your retinas and you aggravate the light sensitivity and you make it worse. The best way I explain this to my patients is imagine you're just sitting in your house and you decide to walk to the mailbox. Maybe it's a little bright out outside. But now pretend that you're sitting in a movie theater and it's really dark for 3 hours, and then you walk outside and you kind of feel like you're a vampire, like you're seeing light for the first time. And that's what dark adapting your retina does. And so what we want to do when somebody's light sensitive after a head injury is we want to reduce the amount of light around, but we don't want to block it out completely. So rather than sunglasses indoors, I usually recommend hats. This decreases some of the light coming towards them, but they're still adapting to it, so they'll recover from it faster. There have been some studies that look into tint assessments. So the light sensitivity tends to be wavelength specific in brain injury. Shorter wavelengths tend to have a higher impact on brain injury patients. Shorter wavelength light tends to be blue light. So that comes from sunlight, fluorescent lights, and a lot of your devices, so computers and cell phones. So as hard as it may be, I often recommend that you stay away from your devices or decrease the brightness on your devices if you have to. And then slowly, though, I always tell patients, because you have the patients that don't want to get better post-concussion and the patients that do. So I want to recommend that initially decrease the brightness on your devices, but then slowly every day step it up so that you can get yourself to adapt back to normal light levels. And then for patients that have other underlying problems, maybe they have a history of chronic migraine, they might be okay to send over for a tint assessment for chronic light sensitivity problems. But if they don't have a pre-existing condition that would make me think that they would need a lifelong tint, then I would often say just try to adapt to it. So I listed this slide here more for your kind of own reading pleasure, but essentially keep in mind that sometimes visual signs and symptoms are not just a concussion, they're an eye problem, and these are the type of things that you want to get an optometrist or ophthalmologist involved in. So for the rest of the presentation, I really want to talk about the bulk of what people have been talking about today, which is ocular motor responses. And so the efferent visual pathway, or how your eyes coordinate, is very, very complicated, and it includes cranial nerves, the parasympathetic and sympathetic system, the frontal lobe, parietal lobe, temporal lobe. It also involves a lot of the vestibular system, and so I don't have too much time today, unfortunately, to go into all the vestibular things, but keep in mind that sometimes the eyes will make us dizzy, but not always. So sometimes people will send over to it for an eye exam to rule out that the eyes are okay and that it's just, vestibular and maybe vestibular spinal. Why do we care about vestibular ocular motor dysfunction? So like I said, if you look in the literature, vestibular and ocular motor are often linked together because it's hard to tell them apart, but it's really common post-concussion. So about 70 to 80% of pediatrics are gonna have vestibular ocular dysfunction post-concussion, and about 20 to 30% of them will have it in post-concussion syndrome. Vestibular ocular dysfunction is considered a risk factor for developing post-concussion syndrome, so you can consider it a prognostic factor. If you see it acutely after concussion, it's likely going to take about 3 to 4 weeks at minimum to get better. And why is that? We have no idea. But we do know that it's really a reason why people are looking at eye movements as a better tool to manage a concussion than, say, balance, right? So we heard earlier, balance is awesome for diagnosing on the sideline, but it gets better really quickly. So we can't necessarily do a return to play protocol on something that gets better really quickly. Symptom scores get better in 1 to 2 weeks, cognitive recovery in 1 to 3 weeks, and on average, ocular motor recovery 3 to 4 weeks. So I've had a lot of athletes where they come in, they pass their best, they pass their symptom scores, they pass their impact, and they come see me and they are not happy because their eye movements tell me they're not ready to go back. And unfortunately, we don't put people back to play in some of the teams that I work with unless they're 100% back to their baselines. Now there's some other mitigating factors that I listed on the right for why people might actually take longer to recover than this normal 3 to 4 days. So if they have multiple concussions, if they have kind of other premorbid factors, then 3 to 4 weeks might be the minimum time it'll take for them to recover. Dr. Goetz did a great job doing my job for me this morning by going over the VOMs. The VOMs came out by the Pittsburgh group in 2014, so if you've never heard of it, it's new, that's why you haven't. And it's really well validated at this point. So they find about 60% of adolescent concussed athletes report symptom provocation after doing just one of these VOMs testings, and that the VOMs is about 90% accurate at identifying patients with concussion from controls. So when we were looking at previous biomarkers from earlier concussion talks this morning, the VOMs is nice because it actually does distinguish between healthy and concussed. There's also been some studies that came out this year, and it's published things that I already knew, which is nice to back up what I say. The only qualm I have with the VOMs is they made it subjective, and eye movement assessment can be objective. I can objectively tell if your pursuits are not accurate. I can objectively tell when your near point of convergence is reduced. And they made this screening system more subjective, so you essentially perform the task and ask if they get a symptom, and so people can still lie about it. However, if you do the test long enough, they will start to get a little woozy, and you'll be able to tell that really, even if they say they're fine, they're not fine. VOMs does not provoke vestibular symptoms in healthy adolescents or adults. So if you don't have a pre-existing diagnosis of vertigo or BPPV, and you have a positive VOMs post-concussion, you can pretty much assume it's from the concussion. They want me to speed up, apparently. So... So I listed this here for your reference. When people have trouble with pursuits and saccades are in different parts of the brain, and so normally we use our eye movements to read. You will notice if you have trouble with your reading eye movements that people are going to complain they lose their place when they're reading, they have trouble focusing. And this is what the King-Devick test has so nicely captured on and why people are using it. King-Devick requires a baseline. There's another test out there called the developmental eye movement test that does not require a baseline, and it does have age-matched norm up to 13 if you work in pediatrics. fMRI has shown that indeed we do have problems in our functional areas related to eye movements post-concussion. And now let's talk about focus. So accommodation is related to the pupils. We know we have pupil problems. That means we have accommodation problems. Accommodation is not linked. That means that the right eye can have normal focus, the left eye cannot. If both eyes have trouble focusing, you're going to have reports of blurry vision up close. But if only one eye has problems focusing, then more likely they're just going to reply that they get tired when they read, or they're fatigued, or they have headaches. Sometimes we have enough amounts of focus, but we're slow to change our focus. Remember, pupils are slow to dilate and constrict. So sometimes we have complaints like, I get really tired when I take notes in class because we're having trouble changing our focus from distance to near. Sometimes our focus will spasm, meaning that we focus so much up close that when we look far away, it's blurry. These ones are really problematic in the office because they'll come in and complain of distance blur. You plop them in your chair and they're 20/20. But if you were to have them look at their iPhone for 5 minutes and then plop them in, have them look far away, they'll have about 20/30, 20/40 vision. Convergence is an issue, so convergence, crossing your eyes from far away to up close, divergence from close to far away. We don't know where it is in the brain, but it's all over the place, and so convergence is often affected after a concussion. People with convergence problems will note double vision, they'll note words moving on the page, and more often than not, they'll have headaches or they'll fall asleep when they read. If we have trouble with our pursuits or our convergence, anything that's linked to our vestibular system, we're going to have visually evoked nausea. Things like scrolling on your phone or your computer is going to give you some symptoms. You can also have symptoms when you're sitting in a car. And if we don't resolve these symptoms, we actually put our athletes at a higher risk of getting another impact because then they're going to have issues with their balance in sport. So we need to make sure that these are resolved before we put them back to play, because we don't want them to get another head injury because they're dizzy when they decide to go in a flip. We don't have time to go through all of the visual processing pathways that I mentioned earlier, but I do want to mention one, and that is our attention. And so visual attention isn't completely understood yet, but it takes a lot of the brain to do it. And so the way that, if you ask anyone's perspective about crowding, if you ask a neuropsych's going to say, oh, it's a cognitive issue. And if you ask a vestibular person, they're going to say it's a vestibular issue. And if you ask a vision person, I'm going to tell you right now, it's a vision issue. So the best way that I can describe it for you is there's two ways that you focus on things when you visually look at things. So if you evolutionarily were to read a book in the jungle, you have a cognitive kind of central focusing area, and you have a peripheral awareness, so that if a tiger were to jump up, you can change your focus from your book to the tiger. But that means that we actually actively inhibit our peripheral vision, even though we're aware of it. And if we're actively inhibiting something and those neurons aren't working very well, that means that we're not inhibiting it, so we're incredibly aware, which means we have this heightened sense of visual ability. This will get us in reading. It won't be that it's blurry, it won't be that it's double. It's when I'm looking at my textbook, which has an incredible amount of visual information in it, I can't read it, but if I cover up half the page, all of a sudden I can read it. It's kind of a weird phenomenon. So sometimes we have to just advocate that they decrease some of the visual clutter in their life so they can actually just interpret it. This really gets people when they decide to do things like go grocery shopping. So I often just tell people that this symptom is normal and it will get better, but you do have to gradually work your way up. So maybe instead of trying to find something in a really crowded aisle at Costco, maybe we start slow with trying to find something in your very crowded refrigerator and work our ways up to kind of stimulating your sense of kind of figuring out what you should be looking at in a very crowded situation. I listed some accommodations you can advocate for in your patients, but my biggest thing is they're temporary. They should never be permanent in a concussion. A concussion is a functional disturbance, not a structural injury at this point in our definition, which means they should be getting better. So where are we going in the future? Well, the Pittsburgh group came out with this great article in 2016 that talked about the targeted evaluation and active management of concussion. Essentially, we need to work together as a team. We need to start screening the ocular, motor, and vestibular systems better. And if we notice something on screening that's not getting better in a typical 3 to 4 weeks, you need to send it to a specialist. Vestibular PTs are great resources, and neurooptometrists are also out there, but we're a little rare, unfortunately, at this point in the game. And the nice thing about this is that we've also changed the way we thought about concussion. We used to think of concussion as this passive problem where we wait to see if they get better. And we found in studies that the groups that really just rested too much and the groups that were too active weren't getting better. So we need to find this kind of middle ground where we slowly work people back into getting into their life. And the active types of rehabilitation that have been shown to be proven effective are vestibular therapy, ocular motor vision therapy, and behavioral therapy. And they're still doing clinical trials right now in vision therapy, but in patients with moderate, severe traumatic brain injury and stroke with vision problems can do small amounts of vision training and get gains for a lifetime. So they don't have regression after they've done these things, which is nice to tell people, put the work in now and it'll help you later. So thank you so much for letting me talk to you guys today. And keep in mind, if anything's lasting longer than 3 to 4 weeks, you might want to consider a vision eval. Good? Good job. Thank you. Yeah. Yeah. Snowy vision, yeah. Yeah, no one understands that one. That one's also prevalent in migraines as well. I have found some patients report reduced symptoms with tints. So low tints to reduce some of the stronger wavelength lights. There's some clinical trials going on in snowy vision at UCSF right now, but no one really understands that one at current. Yeah. Well, I said that, there's not right now. To be honest, as a paradigm, we haven't figured it out. Mm-hmm.
In most cases with recovery, we get kids back to doing whatever they're doing, and if their symptoms return, we have them set back a little bit. Is this the same with ocular and visual things? If it recurs their symptoms, just have them step back and go slower in that whatever therapy they're doing?
So sometimes it's finding a good balance. Oftentimes the vestibular and ocular motor symptoms the vision training or the kind of physical therapy that you do are provoking exercises. They're gonna feel worse before they feel better. Recent studies have shown that making them feel worse in the interim doesn't necessarily prolong, it actually expedites their treatment. But it's finding, so usually I say do the exercise till you get symptoms, stop and wait for your symptoms to recover, then start again. And slowly, the best thing they can do for themselves emotionally is actually log how long it takes till they get symptoms. So it might be, I get symptoms in 20 seconds, and then 2 weeks later, I get symptoms after two minutes. And then slowly they'll notice they're getting better. Okay.
Great job. Thank you, Dr. Teese. Go Bears. Good stuff. We are much more aware of how vision plays a role in all aspects of concussion. I remember back on the sidelines, and the trainers would, give me the 1, 2, 4, and it was really multiple choice, so I passed every time. Our next presenter is Dr. Nancy Chin. Dr. Chin has a master's in speech language pathology and a doctorate in educational leadership. As a regular tenured faculty at Santa Rosa Union College, Dr. Chin recently acquired the Disability Resource and Acquired Brain Injury Specialist Department. In her career, she has co-developed both Santa Rosa Junior College's Sports Medicine Concussion Management Program and Promoting and Supporting Student Athlete Success, PASS program. Dr. Chin has received awards for both of these programs. She has many published works and has given presentations to countless groups. Please help me welcome Dr. Chin, who will present on Return to Learn. Welcome.
Good morning. I think that the theme for today, or one of the themes, is team, right? The team approach and the importance of that. I always feel like I'm coming home when I present with a team of clinicians addressing acquired brain injury. It takes me back to the 1980s, working as a speech pathologist in brain injury rehab, when we thought that we were just the best of the best because we had a multidisciplinary approach. We had PT, we had OT, we had speech, neuropsych, case management, all of these experts working together for one outcome. PT was working on advancing ambulation, speech was working on communication. But what we realized over time is that that wasn't enough, that we could do better, that we needed to have a more interdisciplinary approach. We needed to get outside of our lanes, outside of our disciplines, in order to address the whole patient. So PT, instead of just working on walking, would also address the dysphagia goals. And as a speech pathologist, I would work on transfer training and the cognitive sequence involved in that. And what difference did that make? Well, it made an important difference because our patients were safer, they had shorter lengths of stay, and better outcomes. So this approach applies to concussion management, as Dr. Gross was saying. It's important for us to address the whole student athlete, to pay attention to their return to play, their return to the classroom, and their mental health. As physicians, you are leaders in providing the direction for a safe return to play, but thank goodness we have athletic trainers. I say that every day. And now we have safer return to plays for our student athletes, and we can move our attention to the classroom. What does concussion mean for the student and student athlete? Well, there are three areas to consider. One is that we know that the symptoms of concussion interfere with learning. We know that symptoms may not emerge for 2 to 3 days, and oftentimes, when are they emerging? In the classroom. We also know that increased cognitive exertion can increase symptoms, and simply sitting in a classroom with the overhead lighting and having an instructor speaking to the student can exacerbate symptoms. But I also want to address for you the significance of athletics in return to the classroom and the mindset of the student athlete. Student athletes tend to minimize their symptoms. They have great difficulty complying with rest. They feel stress over falling behind academically, and they feel isolated from their family, which is essentially their team. Can we get some volume up on that?
You hurt your hand or your leg or something, there's always that instinct, like you wanna hide it, you wanna fight through that so that you can continue to play and be successful in your sport. I didn't hide my concussion because my teammates had helped me realize that we took this class and we had this education about concussions and how we shouldn't hide them. And they said to me, actually, if you don't tell someone, I will. And I was like, okay, well, then I'll just go with you. So we both actually ended up going to the training room together. While recovering from my concussion, I had to remember that I'm still a student. And I had to take care of certain responsibilities that I have to my classes and my schoolwork and such. And midterms were actually coming up the next week, and I was panicking. I'm like, oh my gosh, I have a concussion, how am I supposed to think? Well, having the accommodation letters during my recovery was really helpful because I could take my tests, because it was midterms, take my tests in a whole separate room, kind of a quiet area. They were willing to dim the lights if I wanted. I had extra time. I wouldn't have to panic if I saw like a bunch of students getting up and turning their tests in.
For this student athlete, she stayed home several days following her concussion until she got to the point where she was asymptomatic at rest and only had occasional symptoms with exertion, and those could be managed with accommodation. So that made a huge difference for her and her academic success, and she went on to transfer and have great success academically. When we consider the impact of minimizing symptoms with student athletes, we need to think about that this usually isn't on purpose that the student athlete is minimizing their symptoms. This is what they've done for 10 or 15 years. As part of their training, they're trained to push through, to be tough. And the automatic reply that you're going to get from a student athlete when you ask them, well, how are you, is what? I'm fine, right? And so what I've learned is that when I'm asking a student athlete to rate their symptoms on a scale of 0 to 6 on the SCAT, if I say, how's your headache today? They'll say to me, oh, it's just really barely, like a 1 or 2. So what I've learned to do is, okay, rate your symptoms not as an athlete, but as a regular person. What would a regular person rate that symptom as? And that rating almost always goes up to a 3 or 4 because they're not suppressing any longer and filtering through the mindset of the athlete. And how is that significant? It's significant because our student athletes need to be able to correctly evaluate themselves so that they can report out to you as a physician in terms of when they're ready to get back to school or back to play. So it's important to have an accurate ability to assess your own symptoms. We've already kind of gone through the common concussion symptoms. These are the ones that really get in the way of the learning in the classroom. And when we talk about the demands from academics, what are those? Well, the student athletes may have significant exams coming up the next day, the next week. Student athletes are often high achieving. They're not the kind of people that want to just skate by and ignore their homework. They're concerned about missing other classes because maybe they've already had to miss school to go to an event. They're used to doing what it takes and pushing through. And we know that stress and being worried about how you're going to do on an exam or what's going to happen if you can't finish a paper is going to have an impact on their symptoms and oftentimes increase those symptoms. It's helpful for us to consider the psychosocial issues that occur with the student athlete. They often feel like they're letting their team down because they can't participate, and so they feel guilty about that. If the symptoms go on long enough, they're feeling a loss of identity, and they're questioning, who am I if I'm not a football player or a softball player? It can result in feelings of sadness and anxiety, and those feelings can impact academics and overall recovery over time if they persist. Student athletes, athletes in general, are notorious for having a hard time complying with rest. They go from 100 miles an hour to a complete stop after a concussion. And even though you tell them not to, they're sneaky. They will try to find ways to throw in 20 push-ups because they don't want to be deconditioned, or to work on that paper and bust it out and get it done, because that's just how they operate. There are also times when, for some student athletes, they find that they have a loss of a coping mechanism. They were busy, some of them, for a reason. Some of them have not wanted to stop and rest and take a look at some of the emotional issues that they've had in their lives. And when you stop a student athlete and you give them nothing else, there's plenty of time to reflect on some of those. So what is our strategy as an interdisciplinary team? We want to address the minimizing of symptoms and acknowledge the mindset of the student athlete, which again is to be tough and to push through and to grind. What I like to do is to ask the student athlete to take that mindset and apply it to their recovery from concussion. Instead of being tough and pushing through a symptom, you have to be tough and rest. That's what the kind of toughness you have to have. I ask them to be involved in strategizing. What do you need to do to successfully today manage your symptoms? It's important to discuss with the student athlete not only the symptoms that they're having, like how's your headache, how are you feeling in terms of dizziness, nauseousness, but they may not be aware that changes in attention, like if they're feeling fuzzy in class, that's a symptom. Or when they got to the top of the stairs that they're feeling a little off balance, they may not think that's a symptom. And as others have said, we want to provide opportunities for follow-up during recovery from concussion, because recovery from concussion does not go like this. And it's more common than not that a student athlete will return to class and have some kind of exacerbation in their symptoms. The literature recommends staying below the symptom threshold in progressing through recovery from concussion. So in the beginning, considering allowing absences, and then eventually return to school, perhaps focusing on core classes, deferring of exams, extensions on assignments. This is where you as the physician can have such an important impact on recovery. Because student athletes say to me, my doctor said I can't come to school for 5 days. They listen to that. Once they're in school, having a note taker, sunglasses in class, although now I'm going to be looking at hats and not so much the sunglasses, and extra time for exams can make a difference. I spoke with a principal from Maria Carrillo High School, and his takeaway that he wanted me to share was, please provide information in writing. Because what happens in the doctor's office and what's told to the parent does not get translated easily or clearly to the educational environment. So the clearer you can be in putting things in writing, the more helpful that is. And fortunately, the CIF has provided forms online that you can use. We all love a checkoff form, and I've made copies. There's some available outside. The form on the right has a nice list of accommodations that you can check off. This can make a huge difference for the student athlete. The sooner you can get this filled out into the class, the better. And then this is also a really nice guide from the CIF for parents that helps them understand how they can support their child in progressing through the stages for returning to learn. In addressing difficulties with compliance with rest, help the parent identify and the student concrete ways that they can be doing something during their recovery, because we know that doing nothing over a period of time can actually have negative consequences on their recovery. How can they maintain their good nutrition? How can they be involved in their symptom assessment? What are some activities, either art or music or organizing or something that they can do? Because otherwise, those student athletes, they're going to find things to do, and they're going to start doing the things that they shouldn't be doing because they can't stand it any longer. We need to also pay attention to the psychosocial issues. And I had a football player, not uncommon in my office, a linebacker, who said to me, "Nancy, I feel like I'm going crazy," as tears were running down his face, because he said, "I just feel like I'm not the same person that I was." So to be able to provide a place where a student athlete can feel safe and vulnerable, and that they won't be judged if they express these feelings, is really important. A soccer player who said to me, I'm not the same person. Why am I yelling at my teammates? It's so disconcerting. Concussion can really affect our identity. And that's why over time, we may, if those individuals are still struggling psychosocially, we want to make sure we make appropriate referrals, either to one-on-one counseling. At SRJC, we have a weekly concussion discussion group where the student athletes get together as they're recovering from concussion to support one another. And to pay particular attention to the history. Those student athletes who have a mental health history, they may have been doing fine, but this can bring up some of those issues of depression. I had a student who had trauma a year ago and had been pushing it down. She had nothing to do but think about that as she was recovering from the concussion. So something as well to be aware of. For the majority of the rest of my talk, I want to show
Mira
you this
just turned
video.
15. She's a freshman in high school. She plays volleyball both for the high school and for club. She's a high-achieving athlete and a high-achieving academics kid, like all the athletes seem to be. She was at volleyball practice in early November, and she took a power serve directly to the back of her head. And by coincidence, the school athletic trainer was walking through the gym at the time and saw the hit. It was very lucky timing, and I guess he knew immediately that it was a pretty solid hit, and so he ran over and got her and went on the sideline and got her settled down a little bit, and then did a sideline assessment of her, the SCAT-3, and she was pretty shaken at that point and already having quite a few symptoms. When we got to the school, they called us to pick her up. She already had a pretty rip-roaring headache, was nauseous, and extremely fatigued. We took her home. She couldn't take any kind of pain reliever, so it was a pretty rough first night for her because she was in a lot of pain. Her head really hurt. And one of the most outstanding symptoms for her was sound sensitivity. So she just wanted to be in complete quiet. When we left the school, the athletic trainer gave us the SCAT report to take with us and said you should probably see a doctor within 24 hours. And so definitely made the medical referral. And so I went online that night and made an appointment, got one for first thing in the morning. So she was in a doctor's office probably 15, 16 hours after the concussion. So when we got to the doctor's office, we didn't see our primary care physician. We saw another doctor that was taking call. And he asked what happened and told him that she had sustained a concussion. And he immediately went on the computer and pulled up the resources he had for that, and very methodically went through an evaluation of her that was physical, balance, strength, coordination, and also a lot of cognitive woven in. I'm not sure she was even aware she was being assessed. We were in there with him for more than an hour, so it was a really comprehensive evaluation. And then the second half of the appointment was a pretty comprehensive overview of explaining to both Mira and me what was going on with her brain, what to expect, and then a very methodical program for both the return to play and a return to cognitive activities, meaning a return to school, which was the more complex of the two. After we left the physician's office, the next, I'd say 9 days were pretty hard on her. She had some unusual symptoms that were really frightening for her. She was having visual hallucinations that were pretty dramatic. Like we'd be driving home and I remember she said, "How come Daddy's standing out in the driveway in his snow clothes?" And there was nobody there. And she saw a neighbor's dog sitting up on top of some bushes. She saw a mouse running across the floor in our house. I mean, there were probably about 10 different hallucinations that she had, and she's a smart kid, so she said, "I think maybe I'm schizophrenic." I mean, she just went to these very dark, scary places with it. And I tried to reassure her that where she took the hit was probably her vision center, and it was impacting and creating this from inflammation, and to hang in there and just, wait another week or two and hopefully they'd settle down. So that was a lot of her focus. And then another part that was really hard for her was the isolation. She wasn't at school, she wasn't at sports, she wasn't going to music. Her youth group, everything came to a grinding halt, and she was very lonely. We went to work every day and checked in with her, but there was no television, no electronics, no texting. She was on full cognitive rest. And so that was a really hard thing for her, and to have a headache on top of all of that. So it was challenging. So she was, lonely and felt isolated. I don't think the physician was really focused on the psychosocial part. It was really on symptoms of headache, nausea, and what would trigger that. It was really focused on the headache and the symptoms, and a pretty simple progression of, try for 2 hours, and then if you have a headache by that night, then you need to wait until you're headache free for 24 hours. So it was really around the headache, and there really wasn't much about the other. I felt lucky that I already knew that stuff from other reading and exposure that I had from my work. I think it could have been helpful to talk about managing cognitive rest with a teenager, because it's big. Their whole world is cognitive. It's texting and doing homework at the same time while they're listening to music and eating. They're doing 5-6 things at a time, and it's all cognitively taxing. And so to ask them to just flip that switch off, Mira couldn't. And she was motivated to rest because she really wanted to get better. So she did turn her phone off, but she couldn't just do nothing. So, for her, she played piano and she knitted. That's what she did. But, it took a lot of interaction between us to come up with what to do. So having some awareness and talking to parents, I think, about, well, how are you going to pull off cognitive rest with your 15-year-old girl who's, connected to 80 people at once all the time? What does that mean? How do you implement that? A couple of days after the concussion, she thought she was feeling better and she wanted to go back to school. So she's always been such a reasonable kid. We believed her, we let her go back to school. And then she came home with a horrible headache, so we had to pull back. And then she really wanted to go to the last game of the season and just sit on the bench to be with the team. And how do you say no to your kid for that? They've gone through the whole season together. So we went with her, and about 20 minutes into the game, she was physically shaking. The noise inside the gym was making her sick. She got sick to her stomach and felt dizzy and just was shaking. And so we had to leave. And that was probably about 5 days after the concussion. The first time she tried to go back to school, and it set her back. It definitely set her back. Her senses kind of came back to her, and I think she remembered back to the training she must have gotten from her coach or the athletic trainer at school, because she said, I need to wait until I really don't have a headache, because I know that I can make this last a whole lot longer. So she had that information in there, and so I think having had that training from the school for her, as opposed to just parents, made a big difference because she had to own it. I was dependent on her being honest about her symptoms, and I really needed her to be honest with the doctors about what her symptoms were and to feel safe telling them what was really going on without fear that she would be judged about it or viewed as trying to get away with something. School was a huge concern. She goes to a college prep high school, and it's very academically rigorous, and the thought of missing 2 weeks of school, she knew all of her grades would tank. And I had this whole protocol set from the doctor, and sat down and showed the counselor where Mira was in her recovery, and what plan we wanted to do first, with her coming in just 2 hours to sit in a classroom and see if she got a headache, and just be in the environment and see how her brain handled it just by attending to the instructor talking. But accompanied with that was a letter from her doctor, from her primary care doctor, saying, please support this student in her re-entry to school, going through these steps. And I think that made a big difference, having that. It was a more personalized letter. So she did 2 hours, I think, for 3 days. She had a little headache at the end of the first day, but it was pretty mild. So we let her go back the second because she woke up in the morning without it. So she went 3 days at 2 hours, and then she went up to a half day for the next 2 weeks. And then by the following Monday, she was up to a full day and doing all of her work again. The other piece was the acknowledgement that these student athletes are not the type to take advantage of something like this and fake it. Almost all of the student athletes in high school are also high achieving academically, and these things are really important to them. So they're not the kind of kids that are going to try to milk a system, and say, oh, I'm going to get out of doing work. And so, hopefully that assumption isn't made by the schools. I was surprised how long it took, and is still taking. We're 5 months out, and she's still having issues. So that was a surprise to me, that a bump in the head from the volleyball could actually. She didn't even fall down. She didn't lose consciousness. If the athletic trainer hadn't been right there, it might have taken us days to realize she had a concussion. In hindsight, I probably would not have let her go back to school on that third day. I think that was more socially driven, and I was wanting everything to be okay, and so I was kind of blinded by that and hoping that it was. But looking back and the severity of her symptoms the 2 days before, I wish I had been more assertive in saying, no, you are out at least through the weekend, and then we'll see how your head is. So that was just, I caved. I think the most important pieces looking back were getting her in to see a doctor right away, within 24 hours, and having a pretty comprehensive evaluation, and getting as much written material as we did really helped me, because I went back and reread it almost every day over those 2 weeks. And saw something different each time I did, because my attention was focused on different things. So that was hugely helpful.
So, I think this punctuates some of the issues that I addressed in the beginning, which is the importance of addressing the whole individual, the student athlete, the importance of a team approach, promoting rest, considering how the culture of sport impacts recovery, advising the student athlete to stay below their symptom threshold, and playing an active and very direct role in those academic accommodations. You can make a huge difference in their recovery if you can get those accommodations in place, to be alert for the emotional issues and provide opportunities for follow-up. Thank you.
All right, one more round of applause for our speaker. Thank you very much. At this point, I'd like to call up Shana McKeever. Shana holds a master's degree in kinesiology and sports studies with a concentration on exercise physiology and support, and sport performance, a certificated athletic trainer, certified strength and conditioning specialist. She's a certified athletic trainer at San Rafael High School and Marin General Hospital, has been associated with the Marin Triathlon USA Track and Field Cross Country Championships and the U.S. National Figure Skating Championship. Please help me to welcome Shayna McKeever, who will present on Return to Play.
Fantastic. Just making sure I know how to use it. So I'm short, so I'm going to probably stand off from the lectern a little bit. I know I won't threaten the PowerPoint. So today, as Mary Jane mentioned, I'll be discussing the return to play protocol and various considerations that tie into a determination for an athlete to begin the return to play process. So first and foremost, I have no financial interest to disclose. And we're going to start off by talking about the California state laws. There are actually 3, but AB 2127 is also known as Cooley's Law. This is based off of an initial law called AB 25. There are a lot of AB 2-somethings. This one pertains to pretty much high school athletic departments, so participants of any high school level or high school sanctioned athletic event. This requires that any athlete suspected of sustaining a head injury or a concussion may not return to play until they are evaluated by a licensed healthcare professional, and it designates an MD or DO in the text. Additionally, they must receive written clearance by the physician or the licensed healthcare provider to begin the return to play protocol. It also notes that the return to play protocol is a minimum of 7 days or 7 stages, and it can be no fewer. So moving on to the latest and greatest, AB 2007. This came into effect September of 2016, so very recently. And this applies the provisions of AB 2127 to any organization, local government, nonprofit, what have you, that sponsors or conducts athletic competitions, training camps, or clubs. This pertains to patients 17 and under participating in a designation of any of 27 sports. It requires annual education of coaches and administrators for the organization. Additionally, parents and athletes must complete and hopefully review, an annual form that is sent home, and they must have signed, both the athlete and the parent, this form in order to participate even in the first practice. So something that's a little bit tricky with this one is it does not necessarily identify the education that the administrators, coaches, parents must complete in terms of content. Additionally, the organization is to identify the steps for return to play. So that is a little bit alarming because there's not necessarily a guide in which to which to send to the organizations. But it does identify that it must be a minimum of 7 days or 7 stages. So of note, California laws are more conservative than both the Center for Disease Control and the and the Concussion and Sport Group's recommendations for a return to play protocol. So the CDC recommends 5 stages. The Concussion and Sport Group, which was just published within the past 2 weeks, recommends 6 stages, yet California law upholds that it's a minimum of 7 stages. And as I mentioned, the licensed healthcare provider may recommend a more conservative approach, more stages, greater time between the stages, but they may not decrease the number of stages. So the skeleton was originally walking at a leisurely pace to identify subsymptom activity, or an example. I guess he had a lot of coffee this morning. So originally, or currently, the notion of complete rest has been largely based on expert opinion, but now we're beginning to see a shift in the literature. We're seeing this shift away from complete rest towards subsymptom activity. And as you see here, it may actually provide the patient with a better recovery outcome. So some cognitive and physical activity may be beneficial. And this idea of a subsymptom threshold is basically what activity can they tolerate that does not exacerbate symptoms. Are they able to sweep the floor without a problem? Can they wash dishes? Can they bake? Can they go on a leisurely stroll in the evening with an older or mature relative, or walking the dog sort of thing? So the return to play, there was a literature review that was published in March that looked at a variety of factors pertaining to rest and recovery from sport-related concussion. In particular, they found 5 studies that applied to what they were searching, and these 5 studies, all in all, contained surveys from 1,577 physicians in what they use to make a return to play determination. And they found that clinical examination is the most widely used. However, within this, there's variance. What forms are they using? We've seen a variety of forms up on the screen this morning. Are we using the SCAT-3? Now we have the SCAT-5. Sorry, SCAT-4 never existed. Is it a concussion recognition tool, something coming from the coach? Are we using the Center for Disease Control acute clinical evaluation form? What have you. Additionally, balance tests. Are you using the Romberg? Are you using the BEST? Those are the 2 primarily most used. And neurocognitive testing. If it's available, are they applying it in making the clinical determination? So conclusion, there needs to be greater education to providers in order to increase the consistency of care in making the return to play determination. So some challenges that the patient may face, we've heard a little bit about this. Pressure from the coach, pressure from the parents, their own self-pressure, loss of self, or loss of team support. I have up here a note for Zach Easter. Is anybody in here familiar with that name or that story? Okay, so Zach Easter was a young gentleman. Unfortunately, the story does have a tragic ending, but when he started to realize that something was not right anymore, he really started to journal his thoughts, his experience, his changes in personality and character and mood. So Zach played American football from a young age, grew up in a football family, played only through high school. He had been diagnosed with 5 concussions, and in his journal, he admits to hiding others, hiding his symptoms. His senior year, mind you, this is a 3.5-month season, he was diagnosed with 3 concussions. So this will come into play in another, no pun intended, on another slide in the near future. But it's important to recognize that athletes will lie. They are very determined to get back on the field. Their sense of self. For Zach, he admits that he felt that he could not let his team down. He could not let his parents down. They called it the Easter way. Apparently, the family was very tough in being able to push through difficult times. So some comorbidities that we've heard, do we have upper cervical joint injury, vestibular ocular dysfunction, hydration, or, well, at the high school level, it's more of a lack of hydration. So it's important to reinforce proper hydration as, again, we share some symptoms. We've also mentioned that a team-based approach is ideal. We have the healthcare provider, school personnel, the parents, education of the athlete, and if applicable, the athletic trainer can be a great support as well. And then we have the specialists, the neuropsychologists, the physical therapists trained in vestibular-ocular therapies, psychologists, optometrists. So these are all great ways that we can help work together to support the student athlete through this process. Some pre-existing conditions include migraine headaches, depression, anxiety, ADHD, ADD. These may be exacerbated by the concussion, but they may also mask concussion symptoms, particularly if they're taking any variety of medications. So, when might we want to bring up the topic of disqualification from sport? There are currently no evidence-based guidelines from which to start this conversation. It's a clinical judgment. It should be a decision between the licensed healthcare provider, the athlete, and the patient or the parent or guardian if applicable, if they're a minor. It's important to consider the nature of the sport. Is this a 400-meter runner who's having their first concussion, or is this a rugby player with their third concussion in 2 years? Might want to at least put it on the radar in terms of switching sports to a less collision-based activity. The American Medical Society for Sports Medicine position statement notes that some authors do propose disqualification from sport if any of these are met. Structural abnormality on neuroimaging, persistent diminished academic or workplace performance, persistent concussion symptoms or prolonged recovery, or multiple lifetime concussions. There is some evidence in the literature that the more concussions one is sustained, that may prolong recovery from subsequent injuries. So sorry, I love this little clip. Risks of returning to play too early. These include increased reaction time, so you're gonna have a decreased ability to react to a stimulus that's coming at you to avoid a subsequent injury. It can prolong clinical recovery and return to baseline, and too high intensity of exercise can prolong symptoms. My greatest fear as someone who is on the sidelines is second impact syndrome. We've heard briefly about this, but essentially it's when a patient or athlete returns to activity and sustains a second head injury or blow to the chest, to the body, before the initial head injury has occurred. In the literature, you may find that this is seen more often in younger athletes, and this is thought to be due to differences in the brain physiology. So when to begin the return to play? It is a medical decision, and ultimately the goal is to protect the health and safety of the patient or the athlete. The patient has returned to normal cognitive function without symptoms, and for younger patients or athletes, it may be wise to extend the period between stages of the return to play protocol from 24, a minimum of 24 hours, up to potentially 48 hours. Some additional measures that can be taken into account: neurocognitive testing. So frequently in this area, we, as the athletic trainers, typically employ use of the impact neurocognitive test. There's the oculomotor screen, the balance error scoring system, heart rate variability. I find this to be quite an interesting tool. I, unfortunately, myself have not yet had a chance to use it, but it measures the rhythm of the interbeat interval between the R waves. And then the Buffalo Concussion Treadmill Test is an assessment to determine symptom threshold. So to progress through the stages, first and foremost, we must have physician notes or licensed healthcare provider notes that clear the athlete or patient to begin supervised physical activity. It's a minimum of 2 notes. It's a little iffy, sometimes 3. We have the note from the initial visit, return to learn if desired. Then we have a note, as you'll see in a few slides down, to begin the return to play protocol, and then a final checkup, hopefully right around between stages 2 and 3, for full return to clearance. But there is some leeway if the physician note states can begin return to play protocol, may return to sport upon completion of return to play protocol. And if the patient fails to achieve any step after 3 failed attempts, they are to be referred back to the licensed healthcare provider. Of note, it's very important to document the progression, so document the stages. What did they do? What was the date? How long did they do the activity? What were the questions asked, and what were the patient responses? This is very helpful if you need to look back at the chart. Say the patient has failed a single stage 3 times. Okay, let's look at why. What were you doing? And so why do we have a return to play progression? Ultimately, now we're saying that there's physiological dysfunction that can outlast current clinical measures of recovery. And therefore, the return to play provides a buffer zone of gradually increasing activity before returning to full contact or full return to play. So stage 1, we just heard about this from Dr. Chin, essentially return to learn. There's the return to learn protocol if you feel it is warranted. No sports, PE, or conditioning, and it's a minimum duration of 2 days. And before progressing to the stages where we introduce physical activity, we have a physician note that is written and brought to the school or whomever. So stage 2A, light aerobic activity. This was the skeleton before it had its caffeine overdose. About 10 to 15 minutes, just light. I asked the athlete and the parent, do you guys have a dog at home? Yeah, okay. Do you have a route that you could take that's about 10 or 15 minutes? Because that will ensure that there's an appropriate adult there. It must be directly supervised. And it's enough to just get the patient or the athlete out and about and beginning to feel like they're returning to a normal routine. So stage 2B, I should note there are 4 stages of, or 4 activities of stage 2. 2B is moderate aerobic activity, light resistance activity, pretty much body weight exercises for about 10 minutes, and it's a total time of 30 to 40 minutes. And the importance of this is simply to add movement. So walking is a very minimal range of motion activity. Let's look at expanding that. 2C, strenuous aerobic activity, 30 to 40 minutes. Moderate resistance activity, if they previously performed strength training or resistance activity, less than 50% of their maximum for that lift. Total time, 45 to 60 minutes, and the objective is to increase the activity and increase the intensity of activity and begin reintroducing similar demands of sport in a safe environment. 2D, this is the final activity of stage 2, non-contact sport-specific drills. Full resistance activity, as I mentioned, stage 2 is a minimum of 4 days, and the objective is to increase the thinking with exercise and coordination. So we're getting the cognitive input with physical activity. Before progressing to stage 3, where they begin to return to contact activity, must have no return of symptoms, or they've completed stage 2, and a physician note that states, yes, the patient can progress to contact. So stage 3, this is actually broken up into 2 days, ultimately. The first one is 1 full duration practice with limited contact. So if that means participate in 50% of the contact activity, that's an easy way to describe it to the patient or the parent. And if there are no symptoms the next day or 24 to 48 hours next, a full contact practice. As I mentioned, it's a minimum of 2 days. And before progressing to stage 4, which is ultimately return to full competition, no return of symptoms, and full contact practice has been completed. And the objective is to restore confidence. The coaches can help with this in terms of assessing functional skills. Are they able to complete their role in a particular drill? And a reintroduction to contact activity. So stage 4, as I mentioned, return to competition. And this little guy, it actually was another little video with the fist bump, but it didn't come through. So if you guys would like to stay on time, I'm more than happy to stay behind and answer some questions after the fact, or after this is rounded up. Thank you.
Okay, so now we're going to bring up our next speaker, Dr. Eric Freitag, a licensed psychologist, a qualified medical evaluator, and a certified EMT. He's a co-director of sports concussion program at UCSF Benioff Children's Hospital in Oakland. His department provides outpatient treatment to pediatric patients presenting with mild traumatic brain injury. He's provided sports concussion consultation to Marin Catholic, Marin Academy, UC Berkeley Athletic Department, professional cycling teams, and Mike's Bike Elite Cycling Team. He's busy, active professional in a lot of organizations, but you might not know that he's a former professional soccer player. So let's bring up Dr. Eric Freitag.
I'll use my mic piece, but then you guys missed the mic drop at the end, so. All right, so I have a pretty ambitious amount of slides, so I'll hop right into it. I don't have any disclosures, but I'm open to offers. So objectives. So this is 2 presentations into one. So one, we're going to look at targeted management and treatment strategies to facilitate recovery of the post-acute and slow-to-recover patient. And then we'll identify risk factors for post-concussion syndrome, and then we'll wrap things up talking a bit about the biopsychosocial risk factors and other cognitive and psychological issues associated with post-concussion syndrome. So what we understand about concussions can probably best be summed up with this quote. There are known knowns. There are things we know we know. We also know there are known unknowns. That is to say, we know there are some things we don't know. But there are also unknown unknowns. The ones we know, we don't know. Anybody? Who was it? Huh? Nope, not Dick Cheney. Another brilliant 21st century philosopher, that's right. Donald Rumsfeld, 2002. He of course, was commenting on the NFL and chronic traumatic encephalopathy. No, he is actually commenting on the Iraq War, but how salient this is for concussions. All right, let's talk about a case. So this is a 19-year-old healthy female, college intramurals, elbowed while playing basketball, signs and symptoms consistent with concussion, advised by her doctor, complete rest until asymptomatic. She stopped going to class, she stopped exercising, she did not return. It was right like around November, and she basically just stopped that, didn't return for that semester. And she was referred to my clinic approximately 2 months post-injury, so into the second semester of which she did not return to school. She was diagnosed with persistent post-concussion syndrome. So what were her symptoms? She had headache, fatigue, more emotional sadness, sleep difficulties, loss of appetite, and concentration difficulties. So pretty standard post-concussive type symptoms. So we'll come back to her. So let's talk a little bit about the post-acute, slow-to-recover patient, and then we'll get into persistent post-concussion syndrome. So this slide says, offhand, I'd say you're suffering from an arrow through your head, but just to play it safe, I'm ordering a bunch of tests. So again, talking about concussions, of course. All right, so first of all, we've talked a little bit about this, but how long does it take a student athlete to recover? This study was done in 2006 by Mickey Collins over at the Pittsburgh group, and it was mostly looking at high school, or it was exclusively looking at high school and collegiate sport athletes. So if you go and see a medical provider and they say, well, you'll be better in 7 days and then you can return to play, they will be right about 50% of the time, because that's about when the majority of student athletes recover at around that 50% is around the 7 to 10 day mark. I always thought that 7-day mark was interesting because how long is it from Friday to Friday? 7 days. Amazing! I feel better. I can play in the football game today. But of course, if you make that statement that you'll be better in 7 days, you'll get about half of your patients correct. But we also know that half will not be correct. But by and large, the overwhelming majority of our high school and collegiate athletes are going to be better around the 4-week to 6-week mark. So let's talk about post-acute management. So post-acute, my definition is right around that 1 to 5 day mark after the concussion occurs. So we've talked ad nauseum about reduction in cognitive stimulation and mental exertion. We've also talked about decreased physical activity, and we also talked about school accommodation. So I can slide through those pretty quickly. But limiting texting, video games, anything that stimulates or overexerts one cognitively. But what about symptom management in that post-acute period? We don't certainly need to get over-aggressive with medications and whatnot, because a lot of these symptoms can just be managed through reasonable use of over-the-counter medications and lifestyle modifications. So I'm a neuropsychologist. I'm not an MD, so I can't prescribe. So this is how I manage student athletes and patients who come in for the post-acute period by and large. I do feel that over-the-counter use of analgesics is appropriate if they help. In the acute period, that first 1 to 2 days after a concussion, you of course want to avoid any of the NSAIDs that are going to have increased potential for bleeding. Very rare. I think it's probably a little overstated as far as the risk, but why play with fire? After you're out of that risk window, the use of naproxen, ibuprofen, acetaminophen per label instructions can be helpful for some patients, and for some other patients, they say it doesn't really help at all. You want to be very careful about the use of over-the-counter medications due to rebound headaches, and that is a phenomenon I do see quite regularly. In the clinic at UCSF, I generally don't see the post-acute patient. I'm seeing the slow to recover kind of chronic patient, 2, 4, 6, 8 weeks out. And a lot of times these patients have been on acetaminophen or ibuprofen for 8 weeks. And I have concerns that their headaches are no longer actually true post-concussive or post-traumatic headaches, but actually due to overuse or rebound headaches. I'm a big fan of melatonin for sleep. I'm not a big fan of long-term use of it, but I do feel it can be helpful. And there's actually some interesting studies right now showing that melatonin actually has a neuroprotective and anti-inflammatory effect to it. My recommendation for melatonin, just like any other medication, is start low and go slow. So my wife, for example, she'll take melatonin. She'll take 0.5 milligrams, and that is more than enough for her. So she'll do the little Trader Joe's bottle that comes in 0.5, and it's just different for everybody. Now, my recommendation is to start at the 0.5 or 1 milligram dose, and then increase maybe every other night until you get the desired effectiveness. And how you know it's effective is it seems to help facilitate going to bed more quickly, and you don't wake up as quickly. And as a non-physician, I do not recommend going over 5 milligrams unless you talk with their pediatrician or primary care. Because, you can go up to 10, 15, 20 milligram pills, but I don't feel safe with that. And then how you know you're taking too much of the pill, of this supplement, is that you wake up kind of feeling groggy, just more than what's typical as far as just that waking up feeling. So that might be an indication that you've taken too much. This is an off-label use, not a lot of great research to support the use of omega-3 fatty acid, but I do feel it is helpful. There is neuroprotective benefits to it. Not a lot of great studies in concussion, but hey, let's not be research or a nihilist when it comes to clinical practice. It's kind of not a lot of harm in the use of this medication. Of course, it does have some properties as far as bleeding is concerned, so it wouldn't be something I'd recommend going on right away, but in that post-acute period, it could be potentially helpful for recovery, and I view it as a safe supplement to utilize. And 2 to 3 grams for kind of your adolescent to high school, so basically 1 pill, breakfast, lunch, and dinner seems to be pretty easy to remember. And of course, the importance of diet and hydration. So staying adequately hydrated and having a pro-anti-inflammatory diet, whole grains, lean meats, plenty of fruits and vegetables. Trying to treat your body like a temple seems to be the name of the game. And not only concussion recovery, but really any sort of physical illness or medical condition. So that's how I look at things in that post-acute period, and that really doesn't change through the slow-to-recover patient or the chronic post-concussive patient. We still want to maintain these same principles as far as treating your body as healthy as possible, but we do change some of our recommendations as far as rest and rehabilitation, which I'll get into in a moment. But what do I consider a slow-to-recover patient? Now, in the recent international concussion group that just came out a couple weeks ago, their kind of formal definition, what we consider a slow to recover patient, is 4 weeks. And so mine's pretty similar. But I will view that if we're managing a patient properly, so we're following all those acute recommendations, post-acute recommendations, and after 2 weeks, they're still not doing demonstrably better, same or minimal improvement, I would consider that slow to recover patient, and we need to start looking at a little more aggressive interventions and treatment. And definitely, by the 3 to 4 week period, regardless of how you've been treated, that I would consider that to be a slow to recover patient. So, what's the first thing you want to do when you have this chronic or slow to recover patient? Well, one is evaluate the risk factors associated with the delayed recovery. So some of these risk factors are previous history of concussions, especially if they're recent. And I would say recent, within the last 6 months to a year would be something I'd want to look at. If they've had multiple concussions, did each one cause less force, less biomechanical force? I had a athlete a couple of years ago where it was her 6th concussion, and how she got it, she got hit with a bagel in the lunchroom. It wasn't a frozen bagel, it was just a normal bagel. Time frame between injuries is also, there's a lot different between they had a concussion in the spring of 2016 and now how they've had their next concussion. Maybe not so concerning, but is their time frame getting shorter and shorter intervals? And any changes in symptom duration or severity. And there's a saying in concussion management, if you've seen one concussion, you've seen one concussion. And what I mean by that is they're all different. They all present different. They all, each patient may present different as they've had different concussions. But trying to get a sense of, is each one getting a little bit worse, and there's a trend to that is important to determine. Another risk factor is history of migraines or chronic headaches. History of attention deficit disorder or other learning disabilities. Psychiatric history plays a major role in this. And also related to that, psychosocial factors. So high premorbid stress or anxiety, premorbid mood disorders like depression. And then we'll also talk about the influence of cognitive kind of psychosocial biases that can occur that can definitely contribute to extending symptoms. It's also important to look at secondary gain issues. A student athlete, by and large, they're motivated. They want to get back to their sport. But sometimes, maybe not. This concussion can maybe serve a role to help alleviate some pressure, whether it be academic or sport pressure, based on the fact that they can delay the return to whatever sort of life event they're involved in. Other health risk factors, certainly hypertension, diabetes, which as physicians in the room know this isn't necessarily related to just adults. There are kids now with these conditions. Cervical spinal and/or vestibular pathology. I would say cervical spinal is one thing that I see really doesn't get enough or close enough look, where kids come in with clear cervical spinal issues, decreased range of motion, sensitivity in their upper and lower cervical areas, radiating pain, even peripheral neuropathy from that. And it was overlooked because everybody's so focused on the concussion symptoms in the brain that they maybe missed the fact that a lot of these symptoms could be being driven from back or neck or cervical spinal trauma. Sleep is a huge issue as well that requires immediate intervention and discussion. And also talking about iatrogenic symptom provocation, which I'll get into a little bit more. All right, so now we're dealing with the slow to recover patients. So this isn't just the first 1 to 5 days after the injury. This is, kids been dealing with headaches for a while. So this is how I manage it, and this is how I recommend I won't necessarily do all of these things that I talk about in step-by-step process, but it's certainly these are tools that I can utilize, especially being a part of a large hospital system where I do have access to resources. But of course, I utilize my neurology colleagues to help address headache issues. I also work closely with a primary care sports medicine doctor who's a co-director in my program, and I may refer to her to get a little bit more involved, maybe look at medication interventions to address some of these headache issues. And then, of course, by medication interventions, we would want to look at abortive and/or prophylactic type treatments. As I mentioned, careful about the long-term use of over-the-counter medications. Neuro and biological feedback for not necessarily a patient who's had a concussion for a couple of weeks, but if we're talking post-traumatic headaches, 6 months, even a year, where it kind of sets off this latent migraine type syndrome. Neurological and biological feedback has really, I think it's shown some promise in the literature and had some pretty good response from patients. There are a few people that do it in the Bay Area. You have to be careful. There's also a lot of charlatans that can get involved. They go to a weekend seminar and buy whatever system it is that they're selling, and then they say they do it. The ones that tend to be the most reputable in my experience are ones that utilize what's called quantitative EEG biofeedback or neurofeedback, for the ones that are doing neurofeedback. As I mentioned, rule out cervical spinal, which can definitely be a genesis for a lot of headache conditions. Subsymptom threshold exercise, which Shana talked a little bit about, has also been shown to be an effective use and treatment of chronic post-traumatic headaches. And cognitive behavioral therapy is also shown to be quite effective in addressing chronic pain in general and especially headache syndromes. It's important, though, that if you do refer to a physical therapist for cervical spinal or subsymptom threshold exercise, and it's related to every physical therapist should know how to do neck treatment, but if it's related to the concussion, I would highly recommend finding somebody that does have experience in vestibular and concussion treatment. They do have that requisite training. Sleep is, I think, one of the main contributing factors in symptom maintenance. And it's something that definitely is, for me, one of the first things we go to and address. So big thing is addressing sleep hygiene. And we do know that a lot of kids, and a lot of grown-ups for that matter, have very poor sleep hygiene, and I'm probably one of them. Looking at your iPad or iPhone before bedtime, stimulating blue light, which is going to totally screw up with your diurnal or sleep-wake rhythm. More people are sensitive to this than others. Having a lot of electronics in your room, you would be, you probably wouldn't be amazed, but I am every time I hear it. These kids sleep with their phones, and their phone blows up at 2 in the morning because somebody just got a Snapchat reply from their boy they think likes them, and it's like, well, of course you're having trouble sleeping. You're getting text messages at 2 in the morning. So addressing sleep hygiene is a big issue. Another issue that I see is overuse of naps. Now, the first 24, 48, 72 hours after a concussion, it's fine, sleep. If the brain wants to sleep, you sleep. But when you're looking at this post-acute to delayed recovery time frame, they really should not be taking a nap no more than one time a day and an hour or less at the most. I've seen kids that are, multiple naps, 2-3 naps for 2-3 hours, and of course it's going to mess with their sleep-wake cycle, and it's really going to have an impact on their sleep. So always ask them about naps. As I mentioned, melatonin is a good use. There's a good phone app. It's called CBTI Coach, Cognitive Behavioral Therapy Insomnia Coach. It's a free phone app. It's actually put out by the DoD, Department of Defense, and the National Institute of Health. It's meant for use if you're in CBT therapy for sleep as kind of an aid when you're outside of the treatment, but it has lots of good information on it and has ways you can easily keep track of sleep and diary and stuff all on your app. So I know I said just don't use your electronics. So maybe use it before you go to bed and also after. Not while you're laying in bed trying to go to sleep. And then, so I don't prescribe, but just as, if sleep is continuing to be problematic despite these behavioral interventions, then it is worthwhile to look at using some of the medications. I'm more favorable for Lunesta, S-Socliplo, what have you say it, is Lunesta. I'm more favorable as a first-line use. It seems to be a little bit gentler on as far as a sedative and hypnotic than Zolpidem or Ambien is. You won't really find any or very little literature on these medications in use of kids, and especially in use of post-concussive kids. But neurologists I worked with that specialize in this area, that's something that they've advised me on that. Be very careful with benzodiazepine medication and also medications that really have high anticholinergic burden. So, for example, I've seen recommendations for use of Benadryl or diphenhydramine, which has very high anticholinergic impact. And you start messing with those neurotransmitters in the post-concussive period, just not sure how it's going to have an impact on that brain. And also amitriptyline, Elavil, I see very commonly used, and I'm not saying don't use it, but you have to be cautious about it because amitriptyline also has a pretty high anticholinergic burden. And it can't, it's helpful because it can also maybe hit the headaches as well. So I mean, if you go through these tools and that's one of the only things you haven't used and you want to try it, then you should try it. But just maybe think about some of the other side effects or risk factors associated with that. Other slow to recover symptoms that are common are dizziness and nausea, exercise intolerance, or autonomic dysregulation. Those two shouldn't be really grouped together per se, but I have limited time. So one thing is to look for, which is, I wouldn't say common post-concussion, but definitely can happen, is evaluate for POTS syndrome, or positional orthopedic tachycardia syndrome, or orthostatic intolerance. So if I had orthostatic intolerance, I'd be passed out right now because I've been standing so long. And if you ask kids, you get lightheaded if you're standing for a long period of time. Well, yeah, did that happen before the concussion? No, not at all. That could be an indication of autonomic dysregulation, which can happen post-concussion. And it tends to be more common with females than it does with males. Not quite sure why the reason that is. But there are testing you can do measuring heart rate variability, blood pressure variability. I don't do it. We have our athletic trainers or a physician do it. But if we see those symptoms on our interview and screening, that is something we'll look out for. Also consider, if you have these symptoms, vestibular and ocular motor origin, as Dr. Thies so eloquently described. Now for nausea, I'm a big fan of probiotics. I know, do they work, do they not work? It could be placebo, but I really do believe there's a strong, and it's pretty well documented, there's a strong brain-gut connection. And, if your brain's injured, there could be a disruption between that connection. And potentially, a probiotic could be helpful with that. I've had some patients, they started on a probiotic, they've had a lot of post-concussive nausea, and they said it was helpful for them. Now, is it placebo? I don't know. But as far as risk is associated with use of probiotic, it's pretty darn minimal. So, and the other thing that can be helpful is also a ginger supplement, like a hard candy. And you know where you get a lot of those at? Maternity stores. You get ginger lollipops, and so actually I've had patients go in and get ginger lollipops, and if they like them, they use them. Pretty low risk. Ginger does seem to help settle down the stomach, and for whatever reason it works sometimes. In physical therapy, especially for the subsymptom exercise, a physical therapist who's experienced in that can be helpful. And neuro-ophthalmological or neurovision evaluation to address these issues as well. All right, spend a little bit of time talking about psychological symptoms. So one of the first things you can do as a provider that's really helpful is provide reassurance and education about the natural course of recovery and normalize the experience. And in the research, it's really shown that if you just do that one thing when a patient comes and see you, whether it's in the ER or in the primary care's office, and just say, this is an injury, you will get better. I see hundreds of kids like you a year. Everybody gets better. You're going to have these symptoms. They're going to be scary, but that's okay. Day by day and kind of week by week, you'll feel like you'll get better. And if we follow the advice and we follow these steps, we'll get you back to your sport, get you back to your life. Too much of the time, either that discussion's not had, and then they go to Google and they pull it up, and it's like bad. There's lifelong impairments from this injury. You're going to be disabled. You're going to develop dementia, and so that's what's starting this anxiety, negative feedback loop of symptoms. CBT and psychological counseling can be very helpful. And again, I'm not necessarily referring to CBT after 2 weeks, but if we're having, several months of post-concussive psychological symptoms, then I'm going to refer them to treatment. It's important that when you do work with a psychologist or mental health therapist that they are familiar with concussions, at least on the basic level, because they might facilitate some of these kind of horror stories and issues if they're not knowledgeable. An antidepressant can be something worth considering in that chronic period. Mindfulness and stress reduction, just even kind of addressing this, as we talked about in Return to Learn and other post-concussion issues, there's a lot of stress associated with missing school, missing classwork, being out of sports. So one good phone app that I like is called Headspace. It's a guided meditation app. It's free. And it's very good. And there's a couple out there on the market, but Headspace seems to be something that I like. Yeah, it's good. And it's only like 10 minutes. So I was listening to, I think it was Tony Robbins. Sometimes I listen to And he said, but this is a really good quote. He says, if you don't have 10 minutes to meditate during the day, then you need 3 hours to meditate during the day. Cognitive deficits, refer to a neuropsychologist for consultation and evaluation. Make sure your neuropsychologist is experienced and understands concussion and post-concussion recovery, because not every neuropsychologist is necessarily experienced and knowledgeable in that area. Cognitive rehabilitation could be something that's helpful, especially addressing compensatory strategies, stress reduction. Psychostimulants. This isn't necessarily something that we go to very commonly, but it is something that we do consider. So you can use your traditional ADD type medications. There has been some research done on amantadine for post-concussive cognitive issues, especially fogginess. Amantadine is like a 1960s antiviral drug that they use in Parkinson's, and it seems to affect the dopaminergic pathway. Well, it does affect the dopaminergic pathways that they found could be useful in post-concussion cognitive issues. I really haven't seen that effective. I'm not too jazzed on its use, but other people have. All right, let's talk a little bit about rest. How are we doing on time? All right, good, perfect. So is rest best? We kind of touched on this a little bit earlier, but I want to go look at a couple of the early studies that really kind of set off this movement about the active rehabilitation model. So this is a quote from a website, going on Google, beware. The brain needs complete rest for a prescribed time, and you should work with your doctor, and if there's a trainer of the team, work with them. This is about your brain, so there's no cheating. Your brain needs rest and time to heal. The best therapy is to sleep. Right, so okay, what's wrong with this advice? Well, there's no empirical support for this. I mean, in 2002, when we had our first international symposium, concussion group meeting in Vienna, that was the best we knew. We know there was this metabolic disruption in the brain, and you had to rest it and allow it to recover. Well, in that time frame, it was just blew up, and everybody said, oh, rest, 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 rest. And I may have been guilty of that over time. Patients may interpret rest differently as well. What does that exactly mean? You have to be very, cognitive rest. Does that mean just you don't do anything? How do we also define asymptomatic status? I guarantee 99% of you in this room right now have at least one concussion symptom. So how do you define asymptomatic status? And is complete rest consistent with how we manage other injuries? So if you have an orthopedic injury, a knee injury, an ankle injury, I played sports, had plenty of them, you have a period of immobilization, and then you have a period of recovery and rehabilitation on it. So why would the brain, it's all made up of the same stuff, so why would the brain be any different? And also when we look at, this was mentioned earlier, when we look at more moderate and severe traumatic brain injuries, it's you don't rest them. You take care of them and treat them, and they're in the hospital, and then you get them in rehab, and you get them going, you get them moving. Are we contributing to iatrogenic symptoms when we have this over-prescription of rest? So this was one of the early studies out of Giza and Hovda's group down in UCLA. They've done a lot of wonderful work on the metabolic cascade of concussion, and also looking at, really this was in 2004, so this is one of the early studies that looked at rest. So what they did is they concussed these poor rats, and they looked at whether physical exercise in rats is supportive for recovery after they experienced a concussion injury. So exercise was encouraged, and just as an aside, so this device right here is called the fluid concussion device, and it hits this little anvil and hits this, and the water basically blasts out, and they peel back a flap of the rat's brain, and it hits the brain's head with basically a rush of water and causes a concussion. So think about that tonight when you're making dinner. All right, so exercise was encouraged in the acute 0 to 6 days, post-acute 7 to 14 days, or delayed 14 to 20 days. And BDNF, brain-derived neurotropic factor, which is great stuff. If you can figure out how to bottle it and sell it at GNC, you'd be a bazillionaire, but you can't. It's only produced endogenously, and it basically is really one of the great ways that your brain recovers and grows new connections and makes synapses. So that was actually measured as one of the key outcome variables. So rats that exercise at days 0 to 6 had no enhanced upregulation of BDNF, showed decreased cognitive performance, and they had a disruption in the molecular response. So when they were given too much to do too early, it made their recovery longer, made their brain more injured. So that's why we have in that post-acute period, we have that rest over that first 1 to 5 days. And it's different per athlete. But you don't want to get them in doing just too much too soon. That's why it's important that we remove from play and put them on a rest protocol to allow that brain chemical or molecular disruption to kind of settle down itself. The rats that exercised 7+ days post-injury, they had increased upregulation of BDNF, they improved performance on cognitive activity, and the rats that exercised in the 14 to 20-day period, they also benefited, but not as significantly as that group in the 7+ day period. What about with humans? So Letty over at University of Buffalo, they've really done a lot of groundbreaking work in this active rehabilitation model. And this was really one of their first studies that they did where they were like, we may have something here. It wasn't a very well-designed study, so don't let that kind of throw you off. It was just one of the first ones that really kind of set them off. And then since that time, Letty and a lot of other researchers, and especially at Montreal Children's up in Canada and stuff, have done really great work in showing the benefits of this active rehabilitation model. So what was this first study look like? They evaluated the safety and effectiveness of subsymptom threshold exercise training and treatment of PCS, post-concussion syndrome. They had 12 refractory PCS patients, so a very small number, greater than 6 weeks or less than 52 weeks post-injury. And they had a mix of athletes and non-athletes, and there was no control group. So the 5 to 6 days per week of treadmill training, 80% max of heart rate. They had a significant reduction in overall symptom reporting. And all participants returned to pre-injury levels of activity within 6 to 10 weeks. So, I mean, these are ones that are months and months and months of post-concussion, and within 6 to 10 weeks, they're all sent back to their normal levels of activities. But there was no control group. But they have since remedied that, and they found these are repeated studies that have shown similar findings. So what are some active rehabilitation recommendations? Well, an initial period of rest, both cognitive and physically, appears to be helpful in that acute period. The type of rest is dependent on symptom level and tolerance. Duration of rest is variable, but research and clinical experience supports anywhere between 3 to 7 days. So I generally won't start a kid on at least some active rehabilitation, even if it's just going for walks, until about 3 days post-injury. The first couple of days, just chill. Too much physical activity in the acute period post-injury may increase symptoms and delay recovery. We don't know about cognitive activity. Graded resumption of regular pre-injury activity within the first few days to weeks post-injury appears to speed up recovery regardless of symptomatic status. And delaying graded return to activity beyond a month may worsen outcome. Subsymptom threshold exercise appears to aid in recovery after acute period. All right, let's talk about post-concussion syndrome for 5 minutes. So this is what it looks like, ICD-10, DSM-4. It's no longer in the DSM-5. They changed it. I don't know why. I don't like the DSM-5. Questions to consider. What is the true incidence of PCS? Are all individuals with PCS truly experiencing persistent sequelae from brain injury? How do pre-injury factors impact post-injury recovery? So what causes disability in post-concussion syndrome? Is it neurological symptoms like headache or dizziness, changes of personality, irritability, low frustration? Physical symptoms, sleep disruption, fatigue, and of course psychological symptoms, depression, anxiety. You can have one of these, you can have oftentimes it's a convergence of all these issues coming together. But we also know that kind of psychosocial cognitive biases can also contribute to maintenance of PCS symptoms. Concussion sufferers may underestimate pre-concussion symptoms and overestimate functioning, what's called the good old days bias. So this was a study done by Iverson's group back in 2010, and they had post-injury orthopedic controls, and then they also had concussion patients. So what they did is they asked the concussion patients, and they asked the controls, pre-injury, how many of you experienced symptoms? I think I flipped the thing. So they asked them, how many of you experienced pre-injury symptoms of dizziness, right? And the concussion patients very rarely experience any symptoms of dizziness. Only 3.3% said I'd ever had symptoms of dizziness pre-concussion. Where the control said, well, yeah, it happened occasionally. 17% said, yeah, I had some dizziness, before my injury. Temper problems. Only 5.6% of these concussive patients said they had temper problems before the injury. Whereas the controls said, well, about a quarter of them said, yeah, I lost my temper occasionally. So there was this good old, and you look at that, poor concentration, memory problems, difficulty reading. There was this good old days bias where concussion patients had difficulties kind of looking backwards and saying they had any of these issues, and therefore all of these issues now are due to what? Concussion. There's also other biases. Belief that concussion will lead to lifelong disability. You pull it up on Google, boom, you have lifelong disability, expectancy bias. Any non-specific symptom or cognitive errors contributed to the concussion. Attribution bias. Where did I put my keys? Oh, it's because of that concussion. I can't remember where I put my keys. And it can result in anxiety symptom, negative feedback loop. You get worried about where your keys are, and then that happens. All right, I'm going to skip this a little bit here, just get to the treatment part because I'm running out of time. I thought I had 45 minutes just in my own. All right, let me just talk about this really quick, okay? Because this is important. What is a true incidence of PCS? What percentage of patients with concussions go on to develop PCS symptoms that last for more than 1 year? So if you say 50 to 75%, raise your hand. Okay, what about 0%? What about 10 to 20%? More hands. What about you have no idea? That's me. All right, so there is a overabundance in the literature of this 15% have post-concussion syndrome. Who are these 15%? It is based on one research done by Alexander in 1995. And at 1 year post-injury, approximately 15% of MTBI patients still have disabling symptoms. These are not chronic concussion patients where they've had multiple concussions. This is one concussion, okay? This percentage is referenced in multiple studies, internet sources, and even CDC educational material. And he cites two research, Rutherford 1979 and McLean 1983. This is only places where they found this level of PCS. Well, Rutherford, basically, I'm not going to get into all of this, but half of his group were involved in lawsuits. The other half endorsed more symptoms 1 year later than they did in the post-acute period. There was no age or symptom duration, and there were no controls, and age was not related to symptom duration. And there were no symptom validity or malingering testing done on any of these patients. But basically, 19 out of that group endorsed, 15% endorsed still they were post-concussive. Oh, and then finally, 6 out of 19 showed evidence of malingering at 6 weeks post-injury. McLean, I won't go through all of this, but he didn't even do a year follow-up. He did a 1 month follow-up and found that, there was about 15%, but somehow that it got extrapolated to 1 year. World Health Organization in 2004 did 120 best evidence studies on MTBI prognosis, and basically their conclusions were that when you look at and control other factors, especially psychological factors, maybe some other factors that aren't related to the concussion like vestibular or chronic neck issues, you find an overall favorable prognosis and a very limited small subset that endorse persistent post-concussive symptoms. So how do we treat? See treatments for slow to recover patients. That's step one. Target the treatment specific to complaints. If it's psychological, if it's headache, if it's vestibular, send them to the appropriate specialist to get that treatment. When possible, use supervised subsymptom exercise and educate the patient on concussion recovery and treatment protocols. All right, so bottom line with this 14-year-old, or 19-year-old that I presented at the beginning, I got her back into life. Started her on an exercise program, starting her on some cognitive rehabilitation, started her taking some community college classes. Even though she wasn't, quote, asymptomatic, kind of started moving her forward. And basically followed up 2 weeks later, her symptom profile was cut in half. And within a month, she was back to all pre-injury levels of activities. and she re-enrolled into school the following semester. So my take on that patient was many of her symptoms were iatrogenically driven and were a result of this overprescribed rest. All right, so thank you. A little over. And I'll be around after if anybody wants to ask any questions.
Thank you, Dr. Freitag. That was an incredible wealth of information. Some takeaways for me were the sleep hygiene, different than taking a shower and throwing my lava on for bed. So, the snake oil too, I like that one. Watch out for the snake oil out there. So today we are so fortunate to have Dr. James Kovach here as our keynote speaker. Jim is a physician who knows clinically about concussions. As a former NFL middle linebacker for the New Orleans Saints and the San Francisco 49ers, he has experienced concussions. Myself, I've never had one, at least not that I can remember. And as an attorney, well, maybe he'll tell us that Dr. Kovach has also served as the president and chief operating officer of the Buck Institute. Presently, Dr. Kovach is the Translational Entrepreneurship and Industry Relations Consultant Director for the UC Davis School of Medicine. In his role, he elevates participation in innovation, partnership, and collaboration within and outside of the university. Please help me welcome Dr. Jim Kovach, a true Renaissance man.
Thanks, Nathan. Thank you. Well, thank you. I'd like to assure everyone I'm going to keep things fairly brief. There's no time listed with my presentation, so it could be an hour, it could be No, I know a lot of you have had significant coffee before this. I know I have, so a couple of comments, though. First is thanks to the organizers, for Susan, Mary Jane Natu, and the others. Second is, it's been a real privilege to hear the presenters. It's just amazing science, and Marin County really has something special. If you look nationally and even internationally, it's really amazing and a great resource for the community. So yeah, as a young NFL player, I used to play for the New Orleans Saints in the fall, and then I'd drive up and go to the University of Kentucky in medical school in the spring. I did that. Made it through the entire medical school through those 7 years. You can find out more of my 20s at hashtag Those Were the Days. You know, it was a lot of fun back then. So people ask me, obviously, it's like, well, did you realize that this was all going to happen when you were playing? I mean, you'd go from medicine into football, and I was trying to think. It's either a known or a known unknown. I'm not sure which it is, but I know that I remember specifically not knowing or even thinking about that back in the, this is back from 78 to 84. And in fact, small world story, my attending in neurology was Stephen Dukoski, who left the University of Kentucky, went to Pittsburgh, and then in the 80s was the one who worked with Bennett Omalu and was there when all the cases from the Pittsburgh Steelers came out. So that was really kind of the coming out of the potential linkage or likely linkage between repetitive head trauma and some of the cognitive consequences downstream. And so Stephen was my my attending, and I've talked to him many times since, and he did not know, and he was actually portrayed in that great movie Concussion. I don't know if people saw that or not. He felt the guy was too short and was not as good looking as he should be, but yeah. So it's really interesting to see where we were then and how far we've come. Basically, I'm going to talk about kind of the 4 stages. Can we predict and prevent concussion? How can we diagnose it more accurately? Can we identify return to play? And what are the long-term consequences? And so I'm going to take for each of those just one, conclusion or basic belief I have now, speaking a little bit about some of the technologies, some of the science, commenting on the clinical trials, or really the lack of clinical trials, unfortunately, in this space. But the two overarching kind of themes I want to present is first is we know a lot more about concussions. As much as I like technology, I love startups and involved in several through my career. This is still very, very much, I've seen it today, a team-based, human, observational, clinical care path. And I think it's going to remain that way for a long time, actually, for reasons I'll talk more about. But it really makes me admire the physicians and certified athletic trainers who are at the forefront. Basically, it's a battle, and you're on the ground helping the troops, the athletes out there, so you deserve a lot of credit. And then another thing, actually, that I learned when I was at the Buck Institute, my 5 good years here, is that the concept of early trauma, there's an inflammatory response that we saw. Some of the molecular, Richard had a beautiful slide on the reaction and the cascades that are initiated. Then things settle down, there's a long latency, and then there's a late stage consequences many times that we see. And so it's a spectrum that lasts literally 30 years, 40 years from youth all the way to old age, and that is actually relevant to the magnitude of the challenge, I guess I would call it, in terms of developing better methodologies. So first is, can we predict it? When I was here at the Buck Institute, I got very interested in genetics, and so the predictive power, not 100%, but basically from a statistical perspective. And so actually started a company. It was called Athletico. The idea was to take SNPs, genes, and in injury prevention for soft tissue injury, and then also we actually a genotype for ApoE. It's a gene that is associated with Alzheimer's disease. And so we, with 23andMe, actually genotyped 100 NFL players. This work was published in the prestigious journal ESPN, the magazine. And it was very, the idea, I'll just focus on not the injury prevention, the idea was to prehabilitate and to basically get ahead of the curve on soft tissue injuries. But with ApoE, the idea is that we know that 2 copies of ApoE4 are associated with a 10 times higher likelihood of Alzheimer's disease. And evidence shows that the long-term consequences are amplified. So not how quickly someone gets back, that's really not the association with ApoE. But if someone were amplified 3-4 times, then basically a young child with 2 copies of ApoE4 would have a 30-fold higher chance of getting Alzheimer's when that child turns 60, or in that older age. And so to me, that was really important. And so I reached out to physicians. Some got it, some thought it was too early. I actually got Mark Cuban's phone number and called him up. He answered the phone. I was 2 minutes in my pitch, and he said, "That work is way, way, way too early." And I said, "Are you sure it's not just way too early?" No, it was way, way, way too early. And he was right, actually, in the sense that what I found, and what I think is relevant to the predictive market, at least genetics, and number one is it doesn't fit neatly into the care path again. I think it was one of the panelists was talking about diagnosis is essentially the beginning of the care path of a concussion. It's not, how do you handle, identifying the potential, the increased potential someone could have a long-term effect from a concussion. It just doesn't fit in. It's interesting, though, I collaborated with my academic collaborator was a professor at Stanford that recently retired and is now working on sports genes, he calls it, full-time. And if you think about it now, just 7 years, 8 years later, the stringency or the validation of the tools are it's a millionfold better because you can do the entire genome for about the same cost, and he's actually connected with the UK Biobank, so you can get full access to complete electronic health records. So you have now 500,000 to 1 million people, all with their entire gene sequence, and you have their entire health history. So I think on one hand, the technology side, I think there's a lot of promise. Now on can you get it into the market side, I think very, very much less so, just because people, at the end of the day, they don't want to know. I mean, to me, it's amazing, but I think we're still very much a treatment-based society. So it was just it's just kind of an interesting vignette about that area, predictive. The diagnosis, can we diagnose it more accurately? Just briefly, I just want to comment that we've seen here a lot of potential. We've talked about the biomarkers and some of the tests and technologies that have been applied to make better the diagnosis of concussion. The problem is that, number one, those have to be clinically validated. So you need patient populations, you need clinical trials to do that. And they're very much lacking. And so what my conclusion was from today, of watching all these great presentations, it's still very much a physician, basically interacting with a patient to make a clinical diagnosis based on what he or she sees that patient do. And the technologies are still very immature. I mean, we've been saying the same thing for many years now, and I think we will continue to say that, primarily because of the lack of clinical testing. It's not because the companies don't want to do it, but I know that 1 out of every 2 clinical trials, 50%, have either 0 or 1 patient. So clinical trials and running clinical trials is a very, very difficult thing. It's costly, expensive, and it's very hard to recruit patients. So when you think of the hypervariability of the athlete, the presenting athlete, of trying to construct a trial to prove or disprove a hypothesis is very, very daunting. So I personally think that the diagnostic area from an innovation or technology perspective has a tough road ahead of it because of those reasons. One area I'm much more bullish on, actually, is enhancing the return to play pathway, and that is because of therapeutics. I think concussion, if you look at the clinicaltrials.gov or go look at the interest in clinically treating with pharmacological agents to have a better outcome near term and then potentially long term is very, very much, there's a lot going on. It's a very exciting area of drug development. Now, that faces some challenges too. There has to be proprietary molecules, there has to be investment in the field. You have to do the clinical trials, basically, in order to, and you have to have a compound that's protected, it's very difficult. Melatonin, for example, we have anecdotal information about a lot of different inventions. Eric did a great job of citing those, but until you allow a company to come in and make an investment to take it all the way through, phase 3 clinical trials, that is, and recoup its investment and not let freeloaders come right behind it, those trials are just not going to occur. But there's exciting literature out in the field, and even here in Nevada, we have a company that was recently started. It was kind of spun out of Raptor Pharmaceuticals right here that is working on pathways like that could have an impact on these inflammatory pathways, and that's exciting to see, because those would not only have the prospect of improving outcomes near term, but by extension could also impact the longer term consequences. Now, I won't be around for sure to see that, because that's 30, 40 years from now, unless the Buck Institute really gets ramped up, and so so donate now, right? But wait, that's what I used to do. I don't do that anymore. But anyways, that is an exciting area. The last thing is on the long-term consequences. All I have here is a comment about two guys that just both came out this year. 1979, they entered the draft along with me in the same year. Mark Astenot and Dwight Clark, colleagues of mine and friends, and Dwight announced his ALS recently, and Mark announced also he has Parkinson's disease and Alzheimer's, or he called it dementia, which is a symptom. I presume he meant Alzheimer's. But that life goes by quickly, and so that was surprising at one sense, but it's also, it's things like that happen. So people do ask me as well. One of the other speakers talked about, would they let their kids play? I think it was Susan. And they asked me as well. And I think that there are a lot of benefits to football, any contact sport, a team sport. And so my answer is yes. But what I would ask, and the physicians and trainers are in good position to do this, is ask for a commitment, like a contract of someone if they play, then the other elements, the three that I think of through life. And so try to get them to do it for life, because kids will do that. They'll say, yeah, I'll do it, and then they actually remember it. But it would be to exercise, be an athlete your entire life, to eat correctly, and then the cognitive stress, I call it cognitive stress, but staying engaged and really trying to be a perpetual learner. There's several studies out there, including one called the Nun Study, where they followed nuns all the way through their life and then autopsied them, and then determined that many of the nuns who worked until the day they died and seemed perfect had a pretty substantial pathological brain disease. But through neuroplasticity and other mechanisms, their brain figured out how to keep them engaged and not only functional but great members of society. So in closing, what do I see as the biggest advancements? I think it's the team-based approach that has been exhibited here, the fact that we have many different subspecialties working in a coordinated way in our chaotic or somewhat chaotic health environment. It just shows the commitment to athletes and young people. And then one technology that I wasn't mentioned here at all today, but I really am bullish on it longer term, is I'll call it teleconcussion. At the UC Davis, we're one of the leading telemedicine providers in one of the oldest in California. And the advances in basically live streaming and the ability to put two individuals wherever they're at in the planet Earth with low latency and encrypted end-to-end video in the same room is amazing. And there's a guy named Bert Vargas down at the Mayo Clinic who's recently published this month's, I think it's March 24th, Neurology, his most recent validation of the agreement in a clinical exam in person and with teleconcussion. And so it does. The one thing it lacks is obviously you don't know the person, you don't know that athlete, but in terms of a tool that could be available and valuable for that 80% of the population that's out there in more rural environments, I see it as I think you're going to see a lot and hear a lot about it in the very near future if you haven't already. But thanks again to the organizers for inviting me. It was really great to learn and cognitively stress my brain today. And if there's anything, the last thing I've talked to a couple of people, and this Marin has been my home in the past, although I live in Sacramento now. We have a big effort at the University of California, Davis in 22 Division I sports, a very strong interest in looking at and validating new technologies. If there's any kinds of collaborations in this important area that anyone's interested in, I'd be happy to kind of carry the banner for Sacramento County, and we could go, even to the state. I won't be like Howard. I won't go Howard Dean on you, but we could go to the state. We could go to. It is something that is addressed a lot at one level in legislatures, but far less money is behind it. So the way to do that is to get committed professionals banding together and then go making the case before the state. So perhaps we could talk about it in the future. And thank you for attending. And is there any close here? Is this Mary Jane, you on? And a quick close, but thank you very much.
It's so good to see you guys. So just a couple of very quick announcements. Reminder that anyone that's looking for their CME and or CE credits, you'll be granted, though you'll get those after you complete your course evaluation that will be sent to you via SurveyMonkey. And you should receive that email with the link to the survey in the next week or so.
Great, can we get all the presenters to stand up real quick? And on behalf of myself and Mary Jane, big round of applause for all our presenters. Thank you. We also want to thank ConcussionSmart Marin and all those who helped make today possible. If you're part of that committee, could you please stand up as well? And for myself, as the president of Marin Athletic Foundation, we raise money every year to give back to our local schools, to give back to you, the boots on the ground, to promote health, safety, and injury prevention. We really appreciate the opportunity to be here today. Thank you very much.
And we have one more very brief person to make comments. Many of you may know who Dr. Matt Willis is. He's our Marin County Health Officer, and he's the guy that helps Marin County address so many important issues, from immunization to RX Safe Marin, and now here he is today. So, and Matt, you have a very few minutes, as in 2. Here he comes, Matt Willis.
Thank you, Mary Jane, and thank you, everyone. I know that probably the healthiest thing any of us could be doing would be outside, enjoying this amazing weather, and I know I'm the only thing standing between you and that place. I just want to thank you as public health officer for this as a public health issue. Brain health is public health. I spent 6 years racing bicycles professionally before making the error of changing to an academic career. But I recognize that the most important lessons I've learned, I think, occurred outside of the classroom. And I want to make sure that all of our children have an opportunity, and all of us at all ages have an opportunity to do that and have the physical activity we all need and the socialization we need in those sorts of activities to happen safely. I'm going to, I can't read that. It says pics. So I just wanted to show you some pictures of the evolution within my career of helmets. So I started bike racing in 1983, and we actually raced without helmets at all. And then in 1985, we started wearing these little hairnet helmets. And then in 1989, I'm sorry, I don't see it. Sorry. Helmet pics? Oh, there you go. There it is. Sorry. It's a good thing I named them in self-explanatory ways. So this is a picture of me from sponsored by Specialized in 1989. This was like an innovation. These were these helmets, remember those? They were the styrofoam with that little nylon shell over it. I was racing in Europe at that time, and we were the Americans were the only ones wearing those kinds of helmets. The others were wearing no helmets at all, or I'm recognizing more and more of you in the audience. It's just wonderful. This was kind of an American innovation to protect our brains as we raced, ahead of the rest of the world around that. This is the helmet that I was wearing in 1985, that little hairnet. Imagine what that would do if you actually went down. It might sort of keep the fragments of skull together at best, but that's all it would. And then this was in Italy, no helmet at all. So obviously this is an evolving science. This is now my daughter Lily on the Drake mountain bike team wearing a more state-of-the-art helmet. So if it's evolving, there's a chance for us, by definition, if it's evolving, you can be at the near end of the, the sort of the leading edge of that evolution or the tailing edge of that evolution. My invitation to you as public health officers, for us as a community, to be on the leading edge of that evolution. We have a history of success in terms of coming together and collaborating to address threats to the health as a community. Our vaccination rates were 78% just 4 years ago. This year, they were just announced as 94%. So we made huge progress. And we didn't accomplish that by only having our clinicians practice differently. We accomplished that by having community-wide gatherings and really dialoguing around this and understanding where the schools could play a role, where our families and our communities themselves could play a role, where the parents who could advocate to other parents, and the clinicians, right? It's actually a team-based approach. And I love what Mr. Kovacs said in terms of, or Dr. Kovacs, in terms of the innovation here, like the biggest progress is actually the team-based approach, and that applies to the way we approach this as a community. We also made huge progress in our opioids through the same method. We had some of the highest overdose accidental overdose rates to opioids just 4 years ago. This year, we were announced as having lower than state average overdose rates. We had higher than average breast cancer. We had some of the highest breast cancer rates in the nation in the late 1990s. Now, the latest stats show that we have breast cancer rates that are in line with state averages in the state of California. All of those progress basically from this kind of dialogue and this kind of communication. So as a public health officer, I want to thank you for being here today, for recognizing that our greatest asset is our minds, and that brain health is public health, and I'm really looking forward to working with you throughout the next few years to really design a model system as a county to show the rest of the nation how we can protect our best asset. Thank you.